Okay, so now that we've gone through the process of creating a normal set of a Wiggers diagram, what we'll do now is go through an example of how to create a pathophysiological example of a Wiggers diagram. And so one example that we went through in lecture today was aortic valve stenosis. So now what we will do is essentially make these same depictions. So you can go right down the line initially and create a very similar series of X and Y axes on which you will draw your depictions. Save some time this time by not relabeling, because of course you'll have the same labels on the y-axis as the graphs next to you. Okay, and so then now when we start to break this down and we're looking at left ventricular volumes, I think the key thing to do here is actually, when you're starting off, set out your assumptions. And so by that, I mean, when we're talking about aortic valve stenosis, if I said, well, let's talk about somebody who has moderate aortic valve stenosis with relatively preserved left ventricular function, that subsequently we can go through this and we can say, well, let's make a handful of assumptions. One is that there's no change in stroke volume. Okay, so again, cardiac function is preserved, so no change in stroke volume. Similarly, we would say that blood pressure is probably maintained. Systemic blood pressure is maintained. Of course, some of these other changes, I think we'll talk about. Of course, we'll have an increase in velocity across the valve. ECG, we could make the assumption that maybe there's a bit of hypertrophy. Might manifest as a change in the ECG. Heart sounds, again, what I wouldn't expect you to necessarily know, but in this instance, I'll just tell you that generally with heart sounds, you would have a mid-systolic heart sound here, a mid-systolic murmur consistent with the increase in non-laminar flow and increase in velocity of blood going across the aortic valve. But generally, you could say, well, maybe we think that the heart is going to be a bit stiffer because of this hypertrophy. LV thickness is going to be increased because of this hypertrophy again. Coronary perfusion, we're going to be having an increase in left ventricular pressure generated during the systolic phase. So we could say, well, maybe we're going to think that we're going to have some at least greater variability and decreased systolic perfusion. And then for aortic dimensions, I mean, generally, maybe they change, maybe they don't, but at the end of the day, most of the patients that have severe aortic valve stenosis or even mild moderate aortic valve stenosis are above the 5th decade of life, at which point you start to have significant increases in vascular stiffness. So you'd say, well, maybe we've just got a bit of a stiffer aorta. And now let's just go through and sort of draw these things out. So when we are talking about left ventricular volume, so we're going to say, well, there's no change in stroke volume. So again, we can and I guess maybe finally we say, well, maybe there's in terms of ECG, we've got a preservation of stroke volume. So subsequently, we're ejecting out the appropriate amount of blood per beat. So we probably aren't going to increase heart rate significantly. But if you were going to increase heart rate, you want to make sure to compress this horizontally. Okay. So, but we're making the assumption that under these conditions that you were given of moderate aortic valve stenosis, that the stroke volume is preserved. So now when we're looking at left ventricular volumes, again, I think the easiest thing to do is probably just draw in your lines as you would anticipate them being anyway, because heart rate and the timing of events is not necessarily going to be substantively changed. Okay, so when we're looking at left ventricular volume now, again, we've got this period coming up here and a bit of atrial kick there, isovolumic contraction, rapid left ventricular ejection, and we're going to be approximating the same size stroke volume here. And then we'll have relaxation over here. Okay, so here you'd say, well, we've got really functionally stroke volume 1, stroke volume 2, and we're going to say that SV1 equals stroke volume 2. Okay? That's, again, explicit here. When we start to look at changes in blood pressure, again, we're going to start off with our left ventricular pressure trace. We're going to have our initial deviation here corresponding with the atrial kick. And then we'll start off with a period of isovolumic contraction. And since we have aortic valve stenosis, we're going to have a much higher pressure. Probably could have scaled this a little bit better. And then we'll come back down here. And the important thing here is that now, so we've got our augmented pressure trace here because of the greater amount of pressure required to pump the same amount of blood through a smaller orifice with the stenotic valve. Now when we come back and we start to draw in our aortic pressure, again, we're going to start off here and we're going to say, well, that's not really changed necessarily, but this is going to be, we're going to have an augmented pressure gradient there. During the systolic phase. So that's quite clearly augmented over here. And then ultimately we'll then come in with atrial pressure and we will probably argue that atrial pressure, if we've got a little bit of hypertrophy, a little bit of stiffness in the ventricle, maybe we'll have a little bit of augmentation of this pressure that's being generated here. Then otherwise, we're going to say it's just generally augmented just a little bit. And then we'll label these as aortic pressure, left atrial pressure, left ventricular pressure. When we're looking at transvalvular velocity, and now we're going to come through here, largely being at 0. We get to this point where we have the opening of the aortic valve. Again, the same stroke volume being pushed through a smaller orifice is going to result in a dramatic increase in the transvalvular velocity. Depicted there. And ECG, if we're thinking there's a little bit of a hypertrophy, again, we could say pretty readily that again, we've got our P wave occurring here, coming over here, and when we get to our QRS complex, maybe the amplitude of that QRS complex is increased slightly, and that is about the extent of it. And then, of course, we would just say amplitude increased due to hypertrophy. With heart sounds, again, we've got prominent S1 with the S2. We are going to come over here, S2, S3. Again, we would argue that the S3 is really rarely heard. But then with the S4, if the argument is, again, ventricle is a little bit stiffer due to hypertrophy and aging, we now, and over here, may not be evident. Now we're going to say that we've got an S4 sound emerging. And similarly, as I mentioned before, you're not anticipated to know this, but you could draw a subtle sort of mid-systolic sound here, consistent with the turbulent flow through the stenotic valve. When we're looking at left ventricular thickness, Again, now we're going to be coming down here. And then we'll go with a thicker ventricle throughout this entire phase. And the advantage of doing it this way is that then once you create these drawings, then you can say, well, I'm just going to make it quite noticeably thicker. And everybody will know precisely what you're talking about, because then you can just color all this in and nobody will necessarily know any better. And then this is very clearly thicker, certainly throughout the entire cardiac cycle as compared to the normal aged ventricle. Coronary perfusion, we're going to have similar perfusion patterns throughout, qualitatively throughout the cardiac cycle. But again, now we're going to have a more precipitous and larger drop in perfusion during that systolic phase. And then finally, when we're looking at aortic dimensions, again, we wouldn't necessarily think to see a whole lot of a fundamental difference in aortic dimensions in this individual as compared to what we would see in a normal aged individual. So collectively, that would be the strategy and sort of steps that I would take, identifying key assumptions that you think are going to be critical in driving what the shape and changes in a lot of these variables will be as you're drawing the Wiggers diagram. And hopefully you'll be able to apply that to a variety of other pathophysiological conditions, which will ultimately enable you to use this to articulate changes in hemodynamic status with a variety of diseases. Thank you.